Thank you. Now, we have another contentious issue to discuss with Dr. Anthony Hinton. Now, we've seen another block to the removal of lockdowns has been the notion of long COVID. Now, long COVID, of course, is a condition that we've learned a lot about over the last 12 to 18 months, but there's a lot of mystique. Even Chris Whitty in the recent broadcast talked about it being a multiple different syndromes. So what on earth, therefore, is long COVID, and how do we assess the risks, and how do we mitigate any of the potential challenges that come with that? How do we really make sense of that? And that's what we're going to be asking Anthony Hinton about during this conversation, long COVID and its implications. Firstly, Dr. Anthony Hinton, what is the definition of long COVID? What do we know about it?
Well, long COVID really is just the continuation of certain symptoms once your COVID infection has gone. And I would agree, I think it is a mixture of a multitude of things. I think on the whole, it's probably generally fairly positive. I'm going to chat a little bit about the end about my favourite topic, which is why we shouldn't be vaccinating children, and that comes into it a little bit. So we've got probably one group that we could all agree on who probably do suffer from long COVID, but they're a very small group. And that's the people that get COVID so badly that they end up on the intensive care unit. And some of their ongoing problems will be because of the severe COVID infection and the effect it's had on their lungs and their other organs. Some of it will be from some of the treatments that they have to have in ITU to preserve their life. Once you put on a ventilator, that starts to damage your lungs. So that group, I think we can all agree, that is an ongoing group of long COVID that is going to need NHS treatment perhaps for many years. They may never be able to go back to work. But thankfully, it is a tiny, tiny group of people. And perhaps with some of the other treatments that were discussed earlier, we can reduce that number of people going forward if we get another spike of COVID.
Is this something that's distinct to COVID? Again, this is...
No. Well, if you like, the harms that may happen to you on the intensive care unit are the same for anyone going to the intensive care unit for any infection or anybody needing ventilation. But there are probably extra specific things because of the pathological effects that the COVID virus itself has, maybe in certain people that are particularly genetically more susceptible to that damage than others. The next group of, in inverted commas, long COVID patients would be patients with sort of specialty-specific problems. So, for instance, in my own specialty, I'll sometimes see patients with tinnitus, which is noise in the ear, or lack of sense of smell, anosmia, which are undoubtedly in those patients due to COVID. Funnily enough, I've actually seen more patients with those two symptoms after vaccination than I have after COVID. But if you like, that is a form of long COVID. Most of those patients with anosmia and tinnitus will gradually get better. The main thing really from my point of view is I have to check in those patients that there isn't another reason they've got those symptoms, such as a brain tumour. So particularly if you've got someone with noise just in one ear, you have to think, well, could that be from an infection? Why is it just affecting one ear? And those patients have scans to rule out other causes. And then we've got perhaps the more contentious sort of, I suppose, more nebulous long COVID, with a long, long, long list of symptoms of tiredness, fatigue, headaches, lack of concentration, memory loss. I guess that's the so-called brain fog, aches and pains in joints and muscles. The encouraging thing about that is that if we look, I don't know how many of you have been filling in that Zoe app every day. I did that until he suggested that you needed to start vaccinating children, then I stopped doing it anymore. But anyway, I was doing that religiously every single day. And there was very good data in there, but it's all obviously self-reported. But they've got some very, very large numbers, and they've looked at long COVID prevalence. And what they found was for adults at 4 weeks, the prevalence was about 14%. By 8 weeks, it had dropped to 4%. And they did a separate thing for children. And in children at 4 weeks, it started at 4%. And by 8 weeks, it had dropped to below 2%. So, as you'd expect, really, if children get much less severe symptoms with COVID, you'd expect them to get much less of the long COVID. And the vast majority by 12 weeks, their symptoms have all resolved without any with just symptomatic treatment, really. So I don't think long COVID is going to be a long-term issue, for instance, for the NHS. Can we have the first slide on, please? So there are two, but most of these studies of long COVID are just measures of asking patients what symptoms they've got over time. There's no control group. There are two very good studies. This is a German study, and there's also a Swiss study. They're both in children. And what they did, they asked the children about a whole host of symptoms, and you can see all the symptoms that they were asked about and the percentage of children that reported those symptoms. And then what they did in both the studies is they did some blood tests to check which of the children had had COVID and which of them hadn't had COVID. And so the red bar is the children that had COVID. The blue bar is the children that hadn't. And if you can see any difference between the two, you've got better eyesight than I have, because they're virtually exactly the same. So in children, what I would call the problem they have with these symptoms isn't long COVID. I would call it long lockdown syndrome, because this is about what we've done to children. It's not to do with the virus, because there's no difference whether they had it or not. Now, what I really wanted to get onto was, should we be vaccinating children or not? And this plays into that, because at the moment, even though the JCVI, I think David hopefully is going to hold out against this idea, because I think that they're obviously being extra cautious, as you need to be. You know, children get almost nothing bad from COVID, apart from 1 or 2 very, very rare cases. So for children, I would say vaccination is all of the risk for none of the benefit. They don't need it, so why would you do it? But certain people are still pushing for this to happen, and they push for it on, it's to protect adults. Well, there's almost no evidence for that at all. If you look at the number of school teachers that caught COVID and went off with it, it's lower than the general population, and they're in contact with children all the time. You get the same thing if you look at children that were infected and then how many of their family caught it. It seems to be quite difficult for children to pass it on, probably because they have fewer symptoms, and if they're not coughing and spluttering as much, they're not going to pass it on as much. So, and I would say also, vaccinating children to protect adults, I would just say it's totally unethical. Even if it was necessary, it's totally unethical. I mean, my kids' grandparents would say, please do not do anything to my grandchildren and put them at risk to protect me. You know, I've got the option of taking the vaccine myself, and that's what I should do. So that's one reason why people push for it. Another reason is long COVID. But there really isn't long COVID in kids. So 2 of the main reasons that people are pushing for vaccination in children just do not exist. Now, the other thing is this going to be a long-term problem for the NHS, long COVID? Well, there will be those very few, very rare cases that we talked about at the beginning, the people that have been so ill that they went to ITU. Can we have the next slide, please? So this is from some Freedom of Information requests of UK health trusts, and it looks at referrals of children for chronic fatigue syndrome over the last few years. And you can see it went up a little bit, and then it sort of leveled out. Like referrals for everything, They dropped a bit last year and this year. And the little tiny red bar is the ones that have been referred in with possible long COVID. That's it. So it is not going to be an ongoing problem for the NHS. So my main point about long COVID is, particularly as it relates to children, is that it does not justify and should not be given as a reason to justify vaccinating children.
Thank you. I'll ask David in a moment to reply to that. But it's, we've talked here about the implication for vaccines for children, but what about the prospect of further lockdowns in autumn? You know, we're already talking about Freedom Day on Monday. People are speculating that Boris could even U-turn as early as this weekend on what's happening. Long COVID is regularly cited as a reason that the lockdowns are required in order to prevent this burden of disease.
I think all these figures show that that's just not necessary. And if you're not going to open up in the middle of the summer, when are you going to open up? Never is presumably the answer. We've got 90% of adults have had a first dose of the vaccine. I know there are differences of opinion here about the vaccine, but the people that want to continue the lockdown are generally also the people that say, you know, they believe the vaccines work. Well, if they believe the vaccines work, they should be happy to come out of lockdown. You can't have it both ways.
I think what we're seeing is the spillover of what Professor Ferretti talked about earlier, this idea of safetyism, and that people they start to perceive the smallest of risks as personal risks to them.
The government has done an excellent job in frightening lots and lots of people. I have never worn a mask anywhere apart from at work. I've never had an issue with that. It's unscientific nonsense. I don't blame the people that want to wear a mask, and I'm sure for Monday there'll be lots of people that continue. But that's not their fault. They've been brainwashed, if you like. They've been given completely unscientific information that the masks they're wearing and the way they wear them could make no possible difference, maybe increase bacterial infections a little bit. But I don't think they'll do anything to stop a respiratory viral infection. But I think as more and more people do more and more normal things, and those very scared people see people doing normal things, gradually more of those people will also get the confidence to come back and do normal stuff. They won't get confidence by everybody continuing to wear a mask.
Now, I think what's important to recognise here, you've spoken about the specific cases where long COVID is a real problem, and I think for those who have suffered with it, it's important that we don't take that suffering away in the same way that those who have suffered with any form of illness. It's important that we don't do that. But you've talked about the kind of government's behavioural approach. Now, is it when you're talking about the long ITU stays, impacts of inflammation in the body, which are very physical responses? Is there a chance that some of the long COVID we're seeing is almost more akin to PTSD? Is there a trauma-based response that we're witnessing?
Most of those cases that have gone to ITU, that is like 90% physical damage to your body. Although obviously it will have big mental effects as well.
Yes, I'm talking more broadly for long COVID, for those outside that section.
Some of it will be, but those cases are very few. Even when you looked at adults, by 8 weeks, there are only 4% of people still reporting symptoms at all. And these were people that were being rung up and asked, did they still have symptoms? They weren't people volunteering, trying to get a referral to see a doctor about it. It wasn't that severe. And by 12 weeks, there's almost no one left with any symptoms. There will be a few, and some of those are probably from what I would call maybe a population anxiety because of all the other issues that are going on. Lots of the patients that I treat, for instance, with tinnitus, which is this noise in the ears, on average, I used to probably treat those patients for about 4 months before most of them were better or had had a big reduction in the problem and were then able to carry on. I would say now I'm treating those people for twice as long. It's not because they've had COVID, it's because of all the other issues that are going on and all the stresses that are going on. I would say I'm a fairly optimistic person. I'm a fairly laid-back person, but I am getting to the end of my tether with this now.
Now, we will give the opportunity for the audience to ask a couple of questions to yourself as well. But first, Professor Livermore, do you have any comment on long COVID from your experience?
I'm in very, very broad agreement with what's just been said, that we need a clear case definition. On the one hand, you have people who've been in ICU and who do have persistent symptoms long after they've had a very serious illness. But at the other end of the spectrum, you have somebody who's been categorized as long COVID because they've got a bit of a cough 5 weeks after they had a diagnosis of COVID. Well, on that basis, I've had many long common colds in my life. And I have stood many times in the bus queue behind the woman who said, oh, you know, my Henry said she had a bad cold at Christmas and, you know, he's still coughing at Easter. And we've all had that experience. Has poor Henry also had a long common cold? We do need clear case definitions. We need to know, and I believe, and I agree it's a small number, who has got really a long, persistent problem as against somebody who's just got a bit of a cough, which takes a while to get better, but's ultimately inconsequential.
Thank you. Now, the last opportunity for a couple of people from the audience to ask questions to Dr. Anthony Hinton. Lee? Do we have a microphone, please?
Thanks. This is more of a suggestion than a question. People were asking earlier on, how do we convey this kind of information to the general public? And I think one of the more useful things that HART has done is to write up short briefings backed by lots of medical evidence on particular issues such as mask wearing, because it gives people who want to share that information an easy shareable source. Please do one on long COVID, because just in my own personal experience, I have an academic colleague who you would think would be very sensible, very rational, interested in the evidence and so on, is terrified about any changes in the lockdown regulations because she believes that her child will get it and her child will have long COVID. And she genuinely believes, and this is a verbatim quotation, that the government is practicing a eugenics policy on the population. This is somebody who teaches at one of the premier institutions in the country. Lots of people believe this, especially people who read The Guardian.
Oh.
So please write a briefing document on long COVID that we can share.
I have read The Guardian. I don't believe it's population control. I think this started off actually in the correct way. It started off with their very first press conference talking about flattening the curve, that they couldn't change the number of people that were going to die. It was just a matter of when they were going to die until vaccines came along. And they wanted to protect the more vulnerable people, and there was shielding and stuff, and they were going to let it gradually spread through the population. And within a few days, there was an outcry from the press that you're going to let people die, and it all just changed. And they should have stuck to what they were going to do originally. They had a perfectly good, or a reasonably good, pandemic plan that they just threw out of the window for whatever reason. Partly there was that very exaggerated figure that came through from Professor Ferguson, who didn't think it was important enough to obey his own rules that he wanted everybody else to obey. And I'm not even sure anyone listens to those numbers that he comes up with, because he's never got any numbers right in the past. And he's still giving advice. But I try and speak to people. I try and speak to people that I meet. I speak to parents at school. I speak to my patients about it, about things like masks and vaccinating children. Any offer I get to do an interview, I do it. And we should all do that. We should all try and get on everything that we can get on. And I think the media is changing. You know, that there are things that have been talked about in interviews in the last month that would never have been talked about 2 months ago. Even on Radio 4, you believe this, Radio 4, yesterday afternoon, Evan Davis speaking to Lord Billy Mora, who's the bloke that does the Cobra beer, they were talking about ivermectin. Radio 4 on a Friday afternoon, I couldn't believe it. I thought it was like a dream. So, I mean, even a couple of weeks ago, that would not have been on. So I think it is gradually changing. I mean, hopefully they may look at some more of these treatment protocols before we get into sort of, you know, October, November time. Because inevitably there will be an increase in cases. Well, there'll certainly be an increase in positive tests. And the other thing that we need to do for schools is we need to stop testing healthy kids. In Sweden, no kids in Sweden wear a mask. If a child is ill in class, even they aren't tested. They're sent home for a week. None of the other kids are tested. Then they come back. That's it. They haven't all died. They've got much better figures than we've got. And that's what we should be doing. I know that they're talking about changing what they're doing at schools and stuff, but it still is going to involve loads of these tests, maybe done at school now instead of at home. I mean, I just wrote to the school and said, my daughter's not being tested. It's nonsense. It's scientific nonsense. And there was no issue. And I think it's changed at her school from her being the only one of the sixth form that doesn't test. Tilly tells me now that basically none of them do it. They've just got them all piling up at home.
Okay, last question, please. Joe, can we get mic over to Joe Rogers?
Tony, apologies. This is not a question for you. This is for Professor Livermore. I just want to ask, just off the basis of the conversation we've just had, one of the things that I think has been most difficult to deal with throughout the year up until the point of vaccinations was this idea that to get a PCR test is a definition of COVID, but then when people die following or have serious injury following vaccinations, that becomes, so one is causation. You have COVID because you have PCR, and if you die within 28 days, then it is causation, and it's definitely COVID, versus this idea that vaccinations don't have any causation and that it's, you know, somehow just a correlation. And I will just say, I think everybody in this room, and nobody, whatever your views are on vaccines or medical interventions, we are all adults. We all know that all medical interventions have some risk associated to them. But I wondered whether, from somebody who has a strong kind of affinity to vaccines, whether you see the irony of that, and whether you've kind of, what your explanation for that is.
I'm not sure I see an irony to it. You can well argue that there is a double standard being applied here. I think deaths need to be properly investigated. Any death that is shortly after vaccination, you need to look and see whether the vaccine possibly was causal or whether there is another obvious explanation. The coroner should sit on that case. With regard to PCR, lateral flow, etc., these are diagnostic tests which were designed to be applied for a symptomatic patient to assess whether or not SARS-CoV-2 or influenza or respiratory syncytial virus or whatever was the cause of their respiratory symptoms. They have been sorely abused by applying them to wide populations, many of them asymptomatic. I stand to be corrected, but for a long time, the National Chlamydia Screening Programme used chlamydia tests that also happened to look for gonorrhea because they'd been designed for use in sexually transmitted disease clinics. Because the general population incidence of gonorrhea is quite rare, at least whereas compared with chlamydia, most of the positives you got for gonorrhea were actually false positives, and therefore those results were suppressed in the national screening program. And as we heard this morning, once you're in a situation with a low incidence with an infectious disease, then false positives start to become a curse. You also get the point that with SARS-CoV-2, somebody has cleared the infection, but they may have fragments of virus persisting for some time. And I hesitate to call that a false positive. It is a late inconsequential positive. Just as, again, with our old friend gonorrhea, you delay the test of cure for a couple of weeks after you've given them antibiotics and hopefully cured them, because you know darn well if you did the test of cure in a week, you still find fragments of the bacterium. So, sore abuse of PCR tests in the one case and lateral flow tests. In the other case, if somebody dies unexpectedly, whether they're vaccinated or not, then the coroner should sit. That's why I have a coronial service.
But I think that is the point here, is that we're not seeing that. And what we're seeing is a suppression of that data and people saying there's no way this is about that. Yes, we've got... There's exactly the opposite, and that's my concern in this instance.
Well, the coroner has wide powers in the UK, as I understand it. I'm not a lawyer, and Mr. Hoare may well wish to comment on this, but my understanding is that the coroner can demand to hear a number of cases. I've had this in the past when people have died of infection due to a antibiotic-resistant bacterial infection, where the coroner for Shrewsbury said, right, the next one who dies at this hospital, I am going to sit on this and assess involvement. And the same should apply here. But a legal opinion, perhaps? Am I right on coroners?
Mike, please.
Yes, but the problem has been that the Coronavirus Act, this is one thing where the Coronavirus Act has come into play, has required, has made a difference to the way in which coronavirus as a condition is recorded on death certificates, and also there's been a hugely reduced amounts of investigation into those deaths, including non-investigation or cremation before there's any investigation, and they end up on as a statistic. So it's been a huge problem. It's probably far too late now to investigate about.
But that is death due to coronavirus, or with somebody who's had coronavirus, which may or may not have caused the death. The question was regard to somebody who has died rather unexpectedly shortly after vaccination, which may or may not have been caused the death, or may have had a heart attack, which was just one of those sudden things which would have happened either way.
I should of course investigate.
That's what I understood, and we agree.
Thank you very much to our guest speakers. Thank you to Joe for the question.
On that as well, yes?
Please give a round of applause to Anthony Hinton and David Livermore for your